Continuing the heart embryology portion, the right common cardinal vein with that right anterior cardinal vein, they give rise to superior vena cava, right? Then cardinal, subcardinal and supracardinal veins, uh, they give rise to inferior vena cava. Right horn of sinus venosus, that gives rise to smooth part of right atrium, that is also known as sinus venerum. The left horn of sinus venosus, that gave rise to uh, coronary sinus. Primary pulmonary vein gave rise to smooth part of left atrium. Then we have primitive atrium, that would lead to trabeculated part of left and right atria. Endometrial cushion, that gave rise to atrial septum, membranous interventricular septum, then AV and semilunar valves. That means uh, aortic and pulmonic valves. Primitive ventricle gives rise to trabeculated part of left and right ventricles. Bulbous cordus, that lead to smooth parts of left and right ventricle. Then we have truncus arteriosus, that lead to the ascending aorta and pulmonary trunk. So first we have like cardinal veins. Uh, we have the right common cardinal vein and anterior cardinal vein, that would lead to superior vena cava, right? We talked about this. Then we have the posterior cardinal vein and subcardinal and supracardinal vein, that would lead to inferior vena cava. Then we have two types of horn, the right sinus horn and the left sinus horn, right? The right horn of sinus venosus, that would lead to smooth part of the right atrium, while the left horn of sinus venosus, that would lead to coronary sinus, right? Okay, this is on day 22 of the fetus, right? Okay, then there is appearance of first aortic arch. In the med we have bulbous cordus. Now then on day 24 we have sinus venosus, we have atria, we have ventricle, right? And we have aortic roots. Okay, then the pericardium will appear and we have the same truncus arteriosus. The point which we should remember is that the atria is below the ventricle. Then in the during the future formation, the atria will go uh, up and the ventricle will on that position, right? So then on day 35 uh, there is this one left ventricle, right? Then this one we have atria, right? Same thing. Then on day 50 we have like right atria, then we have ventricles. Okay, then we have superior vena cava, that would be formed, right? From uh, the common cardinal, right common cardinal, and with that uh, the interior cardinal vein. Okay, so then we have aortic arch, ascending aorta and pulmonary trunk, that are derived from truncus arteriosus. So once again, right common cardinal vein plus right interior cardinal vein lead to superior vena cava, posterior cardinal vein, subcardinal vein, supracardinal vein, inferior cardinal. Okay, that would lead to inferior vena cava. Right horn will lead to smooth part of the right atrium, that is sinus venerum. Left horn will lead to coronary sinus. Primitive pulmonary vein that would lead to smooth part of left atrium. So this is important, right? Okay. The right horn of sinus venosus that lead to smooth part of right atrium, while primitive pulmonary vein that lead to smooth part of left atrium. This is important. Then we have primitive atrium that would lead to the trabeculated part of the left and right atria. Then we have endocardial cushion that would lead to aerial septum, uh, membranous interventricular septum, and AV and semilunar valves. Then we have primitive ventricles that would lead to trabeculated part of left and right ventricles. Then we have bulbous cordus that will lead to smooth parts, that is outflow tract of left and right ventricles. Then we have truncus arteriosus that will lead to ascending aorta and pulmonary trunk. Okay. Then we have fetal circulation. Blood uh, in the umbilical vein has partial pressure of oxygen of 30 mm of Hg and is 80% saturated with oxygen. Umbilical arteries have low oxygen saturation. Three important shunts. The blood entering fetus through the umbilical vein is conducted via the ductus venosus into the inferior vena cava bypassing hepatic circulation. Most of the highly oxygenated blood reaching the heart via the inferior vena cava is directed through the foramen ovale into the left atrium. Then the third point is deoxygenated blood from the superior vena cava passes to the right atria, then into the right ventricle, then into the main pulmonary artery. From there, through the ductus arteriosus that would shunt it into the descending aorta. Shunt is due to high fetal pulmonary artery resistance. Okay, at birth, infant takes a breath, okay, due to which um, that will decrease resistance in pulmonary vasculature, increase left atrial pressure versus right atrial pressure. So the foramen ovale will close, right? After that, that will be called fossa ovalis. Increase in oxygen from respiration and decrease in prostaglandins from placenta separation that would lead to closure of ductus arteriosus. NSAIDs, example, indomethacin, ibuprofen, or acetaminophen help close the PDA, that is patent ductus arteriosus. Ligamentum arteriosum, which is the remnant of ductus arteriosus. Indomethacin ends the PDA. Prostaglandins E1 and E2 keep PDA open. Okay. Um, what will happen is, if let's say this is the umbilical vein, right? This is carrying the oxygenated blood. This will shunt this blood to the inferior vena cava, right? Then it will um, um, that will shunt the hepatic circulation directly, that will enter the inferior vena cava, right? Then we have the foramen ovale that is shunting the blood between right atria and right ventricle. Okay. uh, then the third, that is ductus arteriosus, right, which is shunting the blood from pulmonary artery uh, through the lungs. That means it is not carrying the blood to the lungs, it will be directly shunted from the pulmonary artery into the aorta, which type of aorta? Descending aorta, right? Okay. uh, the umbilical vein is carrying oxygenated blood, while the umbilical arteries uh, are carrying deoxygenated blood, right? Okay. Now we have fetal postnatal derivatives. uh, Ductus arteriosus postnatal derivative is ligamentum arteriosum, which is located near the left recurrent laryngeal nerve. Ductus venosus ligamentum venosum, foramen ovale fossa ovalis. Allantois, uh, then urachus, that is median umbilical ligament. Urachus is the part of allantois between bladder and umbilicus. And we have umbilical arteries that would lead to medial umbilical ligaments. Medial umbilical ligaments. Umbilical arteries. Okay. Umbilical vein that will lead to the formation of ligamentum teres hepatis, also called is round ligament, contained in the falciform ligament. Once again to this page. Okay, fetal circulation, blood in the umbilical vein has a partial pressure of oxygen of 30 mmHg and 80% saturated with oxygen. Umbilical arteries have low oxygen saturation. Three important shunts are blood entering fetus through the umbilical vein is conducted by the ductus venosus into the inferior vena cava, bypassing hepatic circulation. So this is ductus venosus, right? Most of the highly oxygenated blood reaching the heart via the inferior vena cava is directed through the foramen ovale into the left atrium. Deoxygenated blood from the superior vena cava passes through the right atria, right ventricle, main pulmonary artery, then will be shunted through the ductus arteriosus into the descending aorta. Shunt is due to high fetal pulmonary artery resistance. At birth, infant takes a breath that would decrease resistance in pulmonary vasculature. That would increase left atrial pressure versus right atrial pressure. Foramen ovale closes. Now that would be called as fossa ovalis. Increase in oxygen from respiration and decrease in prostaglandins from placental separation. That would lead to closure of ductus arteriosus. NSAIDs like endomethacin, ibuprofen, or acetaminophen help close the the patent ductus arteriosus. Ligamentum arteriosum, remnant of the ductus arteriosus, will be formed. Okay, endomethacin ends the PDA. Prostaglandins E1 and E2 keep PDA open. Okay, uh, then we have ductus arteriosus, ligamentum arteriosum near the left recurrent laryngeal nerve, ductus venosus, ligamentum venosum, foramen ovale fossa ovalis, allantois, median umbilical ligament, umbilical arteries, medial, umbilical, medial, umbilical ligament. So medial umbilical ligament. Then we have umbilical vein that would lead to ligamentum teres hepatis, round ligament, contained in falciform ligament. Coming toward the anatomy, left atria, the most posterior part of the heart. Left atria enlargement, for example in mitral stenosis, lead to dysphagia, compression of esophagus, hoarseness, compression of left recurrent laryngeal nerve, which is the branch of vagus nerve, that will lead to Orton syndrome. Right ventricle, the most anterior part of the heart and most commonly injured in trauma. Left ventricle is about two-thirds, in right ventricle is about one-third of the inferior, that is diaphragmatic cardiac surface. Once again, left atria, most posterior part of the heart. Left atria enlargement, for example in mitral stenosis, can lead to dysphagia, compression of esophagus, hoarseness, compression of left recurrent laryngeal nerve, which is the branch of vagus nerve, Ortner syndrome. Right ventricle is the most interior part of the heart and most commonly injured in trauma. Left ventricle is about two-thirds and right ventricle is about one-third of the inferior diaphragmatic cardiac surface. So then we have like here superior vena cava, azygous vein. Then on the left side we have aortic, no pulmonary artery. Then we have right area, downward right ventricle. And on the left side, left area, we have left ventricle. Okay, inferior vena cava. Okay, then we have pericardium, consists of three layers: fibrous pericardium, parietal pericardium. Then we have visceral pericardium. Visceral pericardium, also called epicardium. Pericardial space lies between parietal and visceral pericardium. Pericardium innervated by phrenic nerve. Pericarditis can cause refer pain to the neck, arms, or one or both shoulders, often left. Okay, once again, consists of three layers: fibrous pericardium, parietal, and visceral pericardium. Pericardial space lies between parietal pericardium and visceral pericardium. Pericardium innervated by phrenic nerve. Pericarditis referred can cause refer pain to the neck, arms, or one or both shoulders. Okay, fibrous pericardium, parietal pericardium, then we have visceral pericardium. Among them, we have pericardial space. Then we have the uh, visceral pericardium. Below that, we have coronary vessels. Then we have myocardium. Then we have endocardium. Once again, coronary vessels are located below epicardium. This is important. Or we can say coronary vessels are located between myocardium and epicardium. So fibrous pericardium, parietal pericardium, then we have parietal space among parietal and visceral pericardium. Then we have uh, epicardium. Then we have coronary vessels and myocardium. So coronary vessels located between epicardium and myocardium, while pericardial space located between epicardium and parietal pericardium. Right? This is important. Coronary blood supply. NAD and its branches interior to third of the interventricular septum, interolateral papillary muscle, interior surface of left ventricle. Most commonly occluded. Okay. Then PDA posterior one-third of interventricular septum, posterior two-third walls of ventricles, and posterior medial papillary muscle. RCA supplies AV node and AC node. Infarct cause nodal dysfunction, bradycardia, or heart block. Right or acute marginal artery supplies right ventricle. Dominance, right dominant circulation most common. PDA arises from RCA. Left dominant circulation, PDA arises from LCX, that is left circumflex. Codominant circulation, PDA arises from both left circumflex and right coronary artery. Coronary blood flow to the left ventricle and interventricular septum peaks in early diastole. Coronary sinus run in the left AV groove but drains into the right area. Right? Okay. This is important. So the same thing. Okay, once again, LAD and its branches interior to third of the interventricular septum, interolateral papillary muscle, anterior surface of left ventricle, most commonly occluded. PTA posterior one third of the interventricular septum, posterior to third walls of ventricles, posterior medial papillary muscle. RCA supplies AV node, SA node. Infarct, nodal dysfunction, bradycardia, or heart block. Right acute marginal artery supplies right ventricle. Dominance, Right dominant circulation most common, PDA from RCA. Left dominant circulation, PDA from left circumflex. Codominant, PDA from both left circumflex and RCA. Coronary blood flow to left ventricle and interventricular septum peaks in the early diastole. Coronary sinus runs in the left AV groove. This is important. Runs in the left AV groove but drains into the right atria. Okay, good.